Good day, everyone, and welcome to the Bipartisan Policy Center and our focus today on telemedicine in rural America. I am Bill Hoagland, Senior Vice President here with the Center, and I have the pleasure of working with our health team led by Marilyn Serapini, Catherine Hayes, and Dr. Anand Parekh. For those of you who may be unfamiliar with the Bipartisan Policy Center, we were established a little bit over a decade ago by four former majority leaders of the United States Senate, Senator Bob Dole, the late Senator Howard Baker on the Republican side, Senator Tom Daschle, and Senator George Mitchell on the Democratic side. Senator Mitchell, of course, from the great state of Maine, which you will hear shortly, is the state of Maine is very well represented here this morning. The country is indeed the world, quite frankly, is experiencing a once-in-a-lifetime pandemic causing untold suffering and death. Doctors, nurses, hospitals, healthcare providers are struggling to provide critical care under some very difficult conditions. But if there is any good, and there's not much, but if there's any good to come out of this virus, it is that it has expedited the digital health transformation out there designed to help these providers deliver healthcare more quickly and efficiently. COVID-19, I think, has put a laser focus on the use of telemedicine for diagnosing, delivery, and treatment through digital health. Now, obviously, telemedicine was a tool available prior to the onset of this terrible virus. But based on some recent data, telehealth claims have increased 3,500% over this last year. As one of those who has grew up in a rural part of our country and where my family continues to farm today, I am personally very well aware of the challenges of providing health care in a rural America. BPC's health team has been working in this area over the past many years. Last year, BP staff visited various rural healthcare facilities throughout the country, including Maine, with former Senator Olympia Snowe. We saw repeatedly the problems that rural America face in accessing care, the long drives to the doctor's offices, the shortages of both primary care clinicians and specialists, and the rash of hospital and clinic closures. We released recommendations from our Rural Health Task Force earlier this year, chaired by former Senators Daschle and Snowe and former governors Musgrove and Tommy Thompson. The task force recommended expanding broadband to rural communities. It's my understanding that nearly a quarter of rural communities and one-third of tribal communities lack any form of broadband access. We knew that broadband will be expensive and it will take time to implement. So the task force recommended to allow rural Americans to take advantage of telehealth through other means, such as telephone, audio only consultations. We are proud here at BPC that some of the task force's recommendations have made it into the final legislation enacted earlier this year, along with the Department of Health and Human Services Rural Action Plan that they issued recently. But that emergency legislation, the CARES Act, and its provisions surrounding telehealth are scheduled to end with the national health emergency ends, which we hope will be soon. But this brings us to the question that we want to address today, and that is, what is the future of telehealth? What have we learned from the increased use of telehealth during the pandemic, and what new flexibilities should become permanent? We have a wonderful group of excellent people here and to address these questions, and they'll be moderated by the Honorable Senator Angus King. Let me introduce Senator King and then the panel. Senator King is first elected to the Senate in 2012. He's in his second term. He is Maine's first independent United States Senator, and he has played a very significant role in keeping attention on telehealth. He introduced the Improving Telehealth for Underserved Communities Act in June to provide patients receiving telehealth services through certain rural health clinics and federally qualified health centers from having to have reduced Medicare payments. Senator King, former governor, has served as a member of our BPC's honorary congressional task force on rural health. Most importantly to us here at the Bipartisan Policy Center, Senator King is a strong believer in bipartisanship and works hard to bring Republicans and Democrats together to find common sense solutions to the challenges facing the country today. Before we turn this over to the Senator, let me introduce the panelists who will be sharing their experience, but also for all those of you who are viewing out there this discussion. If you wish to submit questions, please submit them through using the live chat function on your YouTube, Facebook, or on Twitter using hashtag BPC Live. Again, it's hashtag BPC Live. So for our panelists, Scott Oxley. Scott is Northern Light Health Senior Vice President and is president of Northern Light Acadia Hospital in Bangor, Maine. Welcome, Scott. Dr. Jennifer Lundblad. Dr. Lundblad is president and CEO of Stratus Health, an independent nonprofit organization based in Minnesota, focusing on innovations to improve health. Dr. Lundblad is a member of the National Rural Policy Research Institute Health Panel. She is also an adjunct professor in the Division of Health Policy and Management at the School of Public Health at the University of Minnesota. Welcome, Dr. Lundblad. And then Dina McDonough, our own Dina. She is BPC's Associate Director of Health Policy. Dina joined BPC after serving as Manager of Payment Policy for the American Academy of Orthopedic Surgeons. Prior to that, she was a physician assistant in, I will say, not exactly a rural hospital, an orthopedic surgery at Mount Sinai Health System in New York City. Then Dr. Lisa Miller. Dr. Miller is a practicing primary care physician for all ages in her hometown of Norway, Maine. She has been one of 4 physician leads on the COVID-19 hospital incident command team for Stevens Memorial Hospital since March. And finally, but certainly not least, Walter Panziger is one of 3 trustees for the Helmsley Charitable Trust. He is grandson of Leona Helmsley and served as a paramedic, a firefighter, and law enforcement officer. This work has led him to create the Rural Healthcare and Vulnerable Children in Sub-Saharan Africa programs within the Helmsley Charitable Trust organization. The Helmsley Trust, by the way, has been a supporter of our work here at BPC, for which we are very grateful of that support. Thank you, Walter. And with that, Senator King, let me turn it over to you and welcome you to this event, Senator.
Well, Bill, it's great to be here, and I want to thank the Bipartisan Policy Center. Although as an independent, maybe I should suggest you change the name to the Nonpartisan Policy Center. Just saying. But in any case, it's wonderful to be here and to join so many people, both on the panel and in the audience. This is one of those frequent occurrences for a U.S. Senator where you're asked to speak to a topic and to an audience, all of whom know more about the topic than you do. And I humbly realize the level of expertise that we have on the panel and in the audience. But I think there are some very important issues to talk about today, and challenges and really enormous opportunities. As you mentioned, one of the few silver linings of this pandemic has been the incredible acceleration of the adoption and expansion of the availability of telehealth. Particularly in rural areas, and that is close to my heart in the state of Maine because we're predominantly a rural state. As everyone knows, during the pandemic, we've seen expansions, both through the CARES Act and through the actions of CMS and DHHS, that have really facilitated telehealth, both in terms of being able to work from home, to have home be part of the telehealth picture, rather than just specially set up sort of health studios. The expansion of people who can provide the help, of practitioners who can provide the help, and finally, the recognition that in some cases, particularly when there's a lack of broadband, a telephone, audio only, is an important part of this. I don't think it can be stressed enough what an important development this is. And it took, I guess it took the pandemic. We all know, those of us that have been working on this for years, and I remember visiting early telehealth facilities when I was governor of Maine 25 years ago, but to see it expand to the level, and everybody's heard the number, at the beginning of the pandemic, 12,000 telehealth visits a week. And by the middle of June, 1 million telehealth visits a week. That's just an amazing, unbelievable change. And it's provided access. And I think people are now realizing that this kind of access is something that should continue, and we should be sure to enable the policies and the reimbursement policies and all the other pieces that enable this to continue. Again, particularly for people in rural areas. I can't speak for other states, but I know in Maine, one of the issues of people in our communities is transportation, particularly seniors. And so saying you can have an appointment at 3 o'clock on Tuesday in Bangor is nice for somebody that's in Patton, but that's pretty much an all-day trip. And to be able to have the visit via telehealth or audio is a huge expansion of the accessibility that people have to medicine and to the kind of treatment. The other thing that I think is very important about this is the use of telehealth for mental and behavioral health, and we're going to talk about this. But I can remember, again, 25 years ago, being told that that was one of the areas that people thought had real promise, and that has proven to be the case. There's a wonderful article, by the way, I will share with you in the Washington Post just this morning, a long article about telehealth and the expansion, and particularly in the field of behavioral health, and how important it is to people to have someone that they can reach out to and have contact with through the telehealth facility. Now, the final thing in my introduction is broadband. Telephone, of course, pretty much works everywhere. Why? Because this country decided a long time ago that universal telephone service was fundamental to the economic, cultural, and social and political well-being of the country. We made the same decision about electricity in the 30s, Franklin D. Roosevelt's Rural Electrification Act. Broadband has developed in a much more sort of herky-jerky, uneven way, where we have terrific broadband, mostly in urban areas, pretty good in suburban areas, okay in some rural areas, and not at all in others. And I believe this has to be a comprehensive, major national priority, just as rural electrification was, just as telephonic communication was, because the economy can't work in rural areas. People aren't going to move to rural areas. And for importantly, what we're talking about today, healthcare is based upon good connection. So that's sort of a separate issue, but it's really got to be part of this discussion, because we can be talking about reimbursement rates and all those kinds of things, but if people can't connect, it ain't going to help them. And so I think we need to be, and as many of you know, there are all kinds of federal initiatives on broadband in the FCC and Department of Agriculture and others. We really need a comprehensive look to make this a clear and comprehensible national policy involving the states, the carriers, communities, co-ops, local people, whatever it takes. We've got to overcome the issues of broadband. So those are some preliminary thoughts. And now I want to call on some of our panel members to make a few opening remarks. And I'll start with Scott Oxley, who's the head of Acadia, which is a behavioral health facility in Eastern Maine, in Bangor, Maine. And Scott, share with us what you're seeing, what's happening on the ground in terms of telehealth, particularly in the behavioral field in Maine.
Great. Happy to, Senator King. And first of all, thank you so much for being with us today, and thank you for your support of healthcare in rural Maine and rural America, and support for those that are in need of mental health services. So as the Senator mentioned, my role is to serve as president here at Acadia Hospital in a state that has a lot of geography and not a lot of resources. Acadia Hospital up here in the central part of the state, we take care of about 2/3 of the geography and about 1/3 of the population. So a lot of area, again, without a lot of resources to cover. There aren't a lot of beds in the state of Maine for acute care services. So part of our success, part of our strategy, and part of our mission is to work very close with folks in the community partners, and doing our very best to get to the folks in their local, in their home space, doing our very best to manage their mental illness, which we all know is a chronic illness. And like any other chronic illness, it makes all the sense in the world to help individuals in managing the compliance and their overall quality of life. So to Senator King's point, what are we seeing here on the ground? Seeing just a huge swell in terms of need for mental health services. And it would be physically impossible for us to keep up with that need, not just Acadia Hospital, but the entire state of Maine, without the benefit of telehealth services. Telehealth services does just a fabulous job connecting to people in need of those services. It's not only a convenience, but it really breaks away a lot of barriers for those folks that are struggling financially, struggling with their illness to get out of their home, and allowing us to connect directly with them. We've got a lot of experience with telehealth. We support 17 emergency departments in the state of Maine, which we've seen a huge uptick of mental health patients needing services, and they're seeking that service, at least initially, through the emergency departments. We're also in 42 primary care practices, where we also see an increase in behavioral health support. But most recently, through the pandemic, we converted most of our outpatient programs to the telehealth platform. And at one point, we're running nearly 100% of our outpatient programs through a telehealth platform. And be happy to share more details later on in the program. But we see the need for mental health services and the acceptability rates through telehealth really on the increase, which we're very pleased and proud of. So thank you.
Thank you, Scott. And Lisa Miller is a physician in Western Maine. It's just a coincidence that there are a lot of Maine people on this panel. I don't know how that happened. But Lisa, you're practicing in a small town, Norway, Maine, in the western part of the state. Again, serving a rural population. And I was on the phone this morning with John Bozeman from Arkansas. And these rural states are, they all have the same kinds of issues. We were talking about broadband. But Lisa, how do you, I guess, let me ask a basic question. Does it work? Does telehealth work? Does it serve the clients? Do they feel well treated and confident in the system? Let me start with that sort of fundamental question.
It does work, Senator King. I would also like to thank you for having me here today to offer a clinical perspective on a topic that I feel has tremendous impact on the practice of rural medicine. I not only think it works, but I think it's been life-saving for my patients. The benefits of it run very deep. Whether it is through a mental health visit with me or teleconferencing in with a specialist about nuanced medical conditions, the value of telehealth spans every age group and level of medical complexity. I just had a telehealth visit last week, in fact, with a 90-year-old patient that went surprisingly well. She wasn't at risk of getting COVID from a high-risk medical facility, but she said to me after, if I can Zoom with my great-grandkids, I can easily Zoom with my doctor. In general, I would say patients are thrilled to not have to take a full day off from work to get something simple checked out. It allows us to be more facile as an industry. It's not uncommon to have patients reschedule a patient or cancel last minute, but we're almost always able to offer telehealth very quickly, negating the need to lose that visit to a no-show status. And I understand your concerns about broadband, and I share them. I would say overall, telehealth has been a huge win for rural medicines, but it does have its challenges, broadband problems or technology glitches being one of them. It's also often immediately clear that the patient needs to be seen face to face to best sort out what is going on, and we will adjust on the fly for that. The scheduling is complicated, and the work behind the scenes to prepare the patient for the upcoming visit requires a heavy lift by multiple levels of support staff. There's also this looming threat that reimbursement streams will go away, or at least not pay as well as in-person visits in the future. The HHS waivers that are currently in place, while not perfect due to inequities in pay rates, have allowed us to quickly develop protocols and workflows to complete the important work of telehealth. We would love to see those waivers continue and hopefully expand. These allow for both operational and financial benefits, mainly that Medicare payments that used to not be covered are now processed as services that are. So the bottom line is, coming from a primary care perspective, we deeply appreciate the importance of getting to know our patients over time. It is this continuity of care that drew us to this field and keeps us in it day to day. This, in its essence, cannot be replaced. When I walk into a room with a patient that I've seen multiple times in the past, I am not only coalescing data about their present illness, but I'm factoring in their social and occupational histories, their family history, as well as the behaviors that occur when they are both sick and well. It is the richness of this knowledge that deepens that interaction with the patient. This is the sole reason why I chose to practice medicine in the first place. In my opinion, this is superior care to a random provider in a distant site seeing my patient for a single acute visit over a screen. These connections have taken years to develop, but once established, the benefits of telehealth can truly be uncovered. Fine-tuning technology, perhaps adding tools that allow for vital sign or physical exam collection, will be keys to advancing and expanding this field. Maintaining the human connection is possible and critical for the care and safety of our patients. Pandemic or not, telehealth should remain a part of the day-to-day practice of rural medicine because of the many benefits it provides to all patients. And I thank you for letting me speak to this today.
Thanks, Doctor. And I hope you'll chime in as we go through this discussion, because I think the perspective of someone who's in the trenches, who's practicing medicine and using this tool is incredibly important. Dina, give us a sort of national policy perspective. What are we seeing in terms of maintaining the waivers that were put in place during the pandemic, and are they, what do you see as the political situation going forward to be sure that we don't lose what's been gained?
Yeah, thank you, Senator, and good afternoon, everyone. We looked at all of these federal changes and potential options as part of our Rural Health Task Force work and the report, which was released earlier this spring. We included policy options that were largely informed by site visits. I remember the drive from Portland up to Norway, Maine, and that weather was really nice. So I can imagine in the snow what it was like. But what we heard again and again was that the frontline providers really felt that telehealth was super important for getting care to their patients. And, many of the providers are caring for populations that span really large geographic areas. So this is also compounded by rural hospital closures that continue to occur. So the task force really drilled down on the legislative and regulatory barriers that are preventing greater utilization of telehealth. And we paid special attention to individuals with without high-speed internet access, and those who are uncomfortable using computers and smartphones. So our recommendations were really more about allowing patients to get care in their homes, allowing the rural health clinics to provide those services, and allowing telephone use. Most of these were implemented as part of the public health emergency, which is great. But as the discussion's turning towards what to phase out and what to make permanent, we really wanted to make sure that the unique characteristics of rural America aren't overlooked. So telehealth is critical for these rural communities, as we'll continue to say throughout this. It was pre-COVID and will be beyond the pandemic. So the flexibilities that were put into place during the public health emergency, allowing patients to receive care in new locations, allowing additional providers and those in urban settings to receive care, are really going to be important going forward. But as data comes out over what happened during the shutdown, we really need to dig into what happened, who was taking advantage of. There was apparently, I think it was 9 million telehealth visits, and 1/3 of those were via audio in the first 3 months of the pandemic. But we don't know, were the audio visits mostly patients in higher age brackets that were just uncomfortable with utilizing technology, or was it working individuals who needed to reach out to their providers, particularly for mental health, which is often multiple touch points throughout the week. So knowing who was using audio and who was using services from home, all these little things are going to be really important going forward to figure out what should come next and what sorts of regulation and legislation needs to be changed.
Well, I hope you all will continue the work of the task force and give me and my colleagues a clear to-do list in terms of which provisions need to be extended. It would just be crazy to lose the momentum that we've built up through this period and then sort of say, okay, well, now that's over, we'll go back to normal. I think the potential of this technology, and Dr. Miller mentioned, we're going to be at a place where people are going to be able to do their vital signs and other physical data for the practitioner also from home. So please be in touch with my office. Megan DeCamp is on this call, I'm sure, and I've got a whole bunch of colleagues that are all lined up to work on this, and I'll count on you all to keep us informed and to keep us moving and not lose the progress that we've made. Jennifer Lundblad at Stratus Health, Rural Health Policy Institute. Give me your thoughts about where we are, where we can go, and how important is this, even outside of the pandemic?
Yeah, Senator King, thank you so much. It is a pleasure and privilege to be part of this session today. I come at telehealth from two perspectives. First, the national policy perspective reflecting the recently released RUPRI Health Panel telehealth paper, which is really focused on how telehealth can contribute to a high-performing health system in rural communities. And then secondly, in a bit of a complementary balance to all my fellow panelists from Maine, from a Midwest perspective here in Minnesota, what that on the ground and in the field perspective is, as my organization Stratus Health works with the telehealth leaders in Minnesota's health systems and rural practices.
Minnesota is Maine without the ocean, just so you know.
Yes. Well, if some people count Lake Superior, you kind of get that Maine feel if you go up on the north shore of Lake Superior. So you're exactly right. And what I would say from all of this, it picks up on the theme that Dina just started. This is the moment to really dig in and deeply understand what's working and what isn't, so that we can inform policy and practice going forward. When COVID-19 arrived and the payment and regulatory flexibilities were put in place, it was like drinking from a fire hose. People needed to ramp up quickly. There was no time to redesign workflow. It was a crisis mode. And the result was extraordinary. We've heard a couple of different data and statistics today, and no matter what you look at, we went from something like single-digit use of telehealth for most encounters to up to 60 or 70% of outpatient encounters via telehealth. In Minnesota, we're settling in somewhere around about 25% right now. But this is the time to take the deep look at what has occurred and understand for what patients does this work, for what services, for what care, what are the ways that we can be smart about taking advantage of this incredible natural experiment that's been underway to inform policy and practice as we go forward.
I serve on the Armed Services Committee, and we often talk about the after-action review. And I think that's exactly what we're talking about here is a careful review, as you say, of what worked, what didn't work, what other changes are necessary, what changes do we maintain. Walter, you've been working in the area of rural health. I remember meeting with you in my office a year or so ago, and I hope that can occur again at some point. But tell me about how you see telehealth fitting in with the whole issue of rural health, which you've been working on for some time.
Absolutely. Thank you, Senator King. First of all, let me give a little bit of background. We were at the Helmsley Charitable Trust into telehealth for over 10 years. I like to say that we were telehealth before telehealth became cool over the pandemic and a natural necessity. The Helmsley Charitable Trust has been in business funding telehealth and rural medicine for the last 10 years. We have funded over $450 million in rural health solutions in the upper Midwest of 7 states. Of that, over $110 million alone just in telehealth in the last 10 years. With that, we have funded, we're in over 420 hospitals for critical emergency, e-pharmacy, those type of telehealth interventions. And being one of the largest telehealth funders in the United States, we see this as a great opportunity right now. We see over the last 10 years, we know what works. We saw what works and what doesn't work with our partners on the ground. And so when the pandemic hit in the upper Midwest, our hospitals and our partners were ready for it. And we see some of the struggles that some of my other colleagues on the panel have spoken to about drinking from a fire hose. And this is such an exciting time now because I really see telehealth on the forefront and telehealth being something permanent because patients are going to get used to using telehealth. Physicians are going to get used to using telehealth. This is a win-win. We've seen long-term on telehealth that we have saved taxpayer and insurance money, millions and tens of millions of dollars on unnecessary transfers, keeping these patients in the smaller critical access hospitals and giving them the highest level of care there with the aid of not just a telehealth conference, but smart technologies to better monitor the patients and remote patient monitorings and different aspects layered on top of telehealth. So I am super excited about the future. I absolutely am very encouraged by the reimbursement rates being temporarily lifted, and I really can see long-term this being a permanent solution to many of the problems we're facing in rural America, from lack of specialty care to lack of physicians, PAs, physician assistants, nurse practitioners, and other family practice physicians that are running these small little critical access hospitals besides their practice, getting the necessary support, being supported remotely. I've talked to countless physicians where they feel supported in rural America. So I'm super excited where this is headed, and I'm really encouraged that this is a permanent way of doing medicine, and the outcomes are awesome from what I've seen. We can talk on more of those and through the panel later on.
Presentation, when he said the outcomes are awesome, do you feel like you're getting positive outcomes I'll ask you the same question I asked Dr. Miller. It works?
Yes, from what I've seen on the outcomes, a good telemedicine visit should be no different than an inpatient visit. The outcomes should be the same. And we've seen those outcomes being so positive. For an example, Senator, I have heard countless stories of patients coming to the local access hospital presenting a stroke and being able to have the local physician, which may sometimes is a mid-level, sometimes it's a family practice level, have an e-consult with a board-certified emergency room physician, bring on board a neurologist, determine whether the patient is a candidate for TPA, and push the life-saving clot-busting drugs into the patient at this critical access hospital. When traditionally, they wouldn't have a neurologist consult. This patient would have to be packaged and shipped to a larger tertiary hospital. And a lot of times, especially when you look at neurology and cardiology, if you don't get that life-saving intervention on immediately or in a small time window, that patient is no longer a candidate. So we're seeing these patients in rural America where they're getting this life-saving treatments, where in the past, they wouldn't be receiving this life-saving treatment. They would be packaged and sent to the tertiary facility, and most they can do is probably rehab from the stroke from there. So yes.
Let me ask Scott Oxley your view of the efficacy, particularly in the behavioral health field.
Yeah, thank you very much, Senator. When we converted a large portion of our outpatient program to telehealth, I was a little concerned about two things. One, the efficacy. I wanted to maintain our strong outcomes, to know that our work was making a difference in terms of quality of life for our patients, but also from a patient satisfaction perspective. Because if we didn't make this a convenient, excellent experience for the patient, they weren't going to engage. They wouldn't get the care that they needed, and obviously their condition would deteriorate. But not to my surprise, but to the good work of our team here at Acadia, I learned pretty quickly that telehealth is truly a team sport. It's not just the folks on the front line providing that clinical encounter, making sure they get the treatment that they need, but making sure the patient is ready to engage in the encounter, making it easy to access from a technology perspective, a scheduling perspective. So I was just very pleased to see that over time, satisfaction rates, what we saw consistently across the board with our internal sampling, was there was an excess of an 80% satisfaction rate with engagement with the service. In fact, many of our patients prefer telehealth over the live visit because it simply works for them in the way that they're battling their illness. The issues with stigma with the mental health population allows them to get the service in the privacy of their own home, in an environment that they're very comfortable with, where they have those local family supports. It's just an exceptional way to deliver care for psychiatric treatment. We've always maintained a diligence with outcomes and the quality of our service. And not only did we hold our own in terms of the efficacy of the product that we offer, we actually saw a 6% increase throughout the pandemic as we got deeper into the pandemic and we converted more of our business to telehealth. We saw the outcome scores and the quality of our product actually increase. So from both fronts, from a quality of service as well as satisfaction of service, we find that telehealth or telepsychiatry really hits the mark here in our part of the world.
That's exciting to hear. Let me talk, Dina, maybe I can start with you or have some of our practitioners. This is a loaded question, but how about reimbursement rates? Are they adequate? Too low, too high? Should they be the same? Should there be no distinction between an in-person visit and a telehealth visit? I know at the beginning the telephone visit was ridiculously low, and that was increased, and that made a big difference. Talk to me about that issue.
So question. Thank you. It really is going to come down to outcomes and how the care is provided, what patients feel about it, as Scott was just saying. When you're talking about some sorts of visits, the leap is much smaller than others. When you're talking about something where the laying on of hands is less important, therapy and just maybe a checkup or a reviewing of tests, it's much easier to see that the work going into those services is pretty comparable, whether the person's in front of you or at home. But when you start talking about having to do physical exams, there are people, one of the site visits that we went to in Wisconsin, they showed us that they are giving patients a kit that allows them to look in their eyes, look in their ears, listen to their heart, check their blood pressure. They're doing all of the same vital signs and examination using technology. And so if that's all happening, what's to say that one visit should be paid more than the other? And as someone mentioned, the idea that when you remove as it is now, where a patient needs to go into a clinician's office and be linked up with another provider, when you have that patient at home and the distant provider is the only provider, they take on twice the burden of setting up that call, making sure that the patient's technology is working. And so the burden does increase for that provider now. So the way it's done now is, this is going to get a little weedy, but the way it's done now is there are different payment rates for services, whether a patient is in a hospital setting or a doctor's office. And they split those payments so that if you're in a facility setting, the payment for the service itself is a little lower because the overhead and all that burden that I'm talking about is absorbed through a separate payment. When you have a patient having services from home, they are only getting paid 2/3 of what the actual full price would be. So some of that money is getting lost as we move the patient to the home, even though the work is doubling for the provider. So there's a couple different things that need to be looked at, and again, drilling down on how these services were used, particularly audio versus video, is going to be really important to inform how we reimburse the services going forward.
Well, when we're talking about costs, let's not forget about cost to the patient. The transportation costs, the time costs, the opportunity cost to the patient, I think is really significant. I mentioned, Patton, Maine to Acadia. That's a day, both ways. That's a day, as opposed to an hour or an hour and a half, whatever the visit takes. So I think that's got to be a consideration. And ultimately, if we move in this direction, there may be some lower overhead cost. As you say, there may be higher costs for setting up the meetings, but also less bricks and mortar, ultimately. Now, let me raise a difficult issue using a word that seems to have crept into our lexicon lately: fraud. Is there any additional danger of fraud in this structure where you have calls about keeping track of how long the visits are? And one of our audience members raised this question. Anybody want to take a crack at that one? Everybody's quiet on that.
Yeah.
Have there been any?
Yes.
Have there been any issues raised that you know of during this period of improper billing or that kind of thing?
I can
Senator
take
King,
a crack at that one. During COVID, I can't speak to the COVID period, but throughout our experience and with our partners over the last 10 years, these things, from what my understanding, have been billed just like they would be for a normal visit. There's proper documentation built in that becomes part of the patient care record. So, with a video conference and seeing the doctor, seeing the nurse, whatever the discipline was, or whichever discipline was in there, whether it was a specialist or the family practice physician, it's all documented of what was done, just like anything else. So I don't see fraud being so much as an issue because it's documented in the patient care record. You can see exactly what was done. So that way they can put in the proper codes for billing. And I think the risk for fraud is no different than an in-person risk, especially if you have the documentation built in. And from my understanding, all our partners do have the documentation built in. I'd be astonished to find out that people are having televisits without documentations. I think every lawyer in all these companies and the hospitals would have a stroke if they knew, if they even thought that was going on, just because of litigious actions.
You could treat the stroke via telehealth.
Exactly.
A question that talks about institutional change in order to adapt to this technological change. What about licensure and across state line practice and state compacts and that kind of thing? How is that issue going to be? Is that just a matter of time and state law? Because the internet doesn't certainly respect state lines, let alone county medical association lines.
I could answer that one real quick. As you know, with our partner Vera, we funded in over 7 states, and Vera's in Vera Medical. The Vera Hospital Group is providing telemedicine in over 30 states. And licensure is a problem. Licensure can be difficult. I remember early on, things have gotten way better with licensure. Early on with partnerships with Vera, their physicians would literally have one dedicated person sending out 10, 15 different licensure forms, fingerprints, background checks. It became very cumbersome, very difficult to be licensed in multiple states. Things have gotten better, but I'm sure other people on this panel can speak to it. There still are challenges. Not every state recognizes a license from another state, and some states still make you jump through those hoops that I described. But things have gotten better, but there's still challenges.
Other members of the panel want to speak to this issue of licensure and sort of those kinds of regulatory barriers? Is that the next step in this process?
Yeah, Senator King, this is Scott. I do agree with Walter. I think there's opportunity there, but if you think about this as one component of workforce development, I think we have gotten so much more benefit to date through the use of telehealth by allowing us to expand our workforce. We have 57 providers on our medical staff, a combination of psychiatrists and psychiatric mental health nurse practitioners. About 15% of that workforce work every day from a state beyond the borders of Maine. So we have 9 individuals in 8 different states working with us every day to provide a combination of care to both outpatient and inpatients, and not just at our hospital, supporting many of the clinics and practices that I referenced in my opening remarks. So I do agree with Walter. It's a little cumbersome to work through. It hasn't been a showstopper, but so far, being able to extend our workforce, both on an inbound and outbound basis, has been such a benefit to us that we're just happy to have extra providers available to take care of people from Maine.
Dr. Miller, you mentioned in your comments that we're moving toward home monitoring of vital signs and others. Do you see that as a potential significant growth area in terms of making telehealth more efficacious?
Absolutely. And there are quite a few home health agencies in Maine already doing that. A patient will get discharged from the hospital very ill and know that they need closer monitoring. And so they're actually sent home with a kit that Dina had mentioned to monitor vital signs, check weights if there's a history of congestive heart failure, et cetera. So it's already happening, but I think that there's opportunities to expand that as we look to other options for telehealth. Just the other day, I was asking my colleague, what are some of the advantages that you found beyond just the obvious? And she said she has several patients that are literally homebound that can't get into the office, will make appointment after appointment, and they'll no show or their transportation will fall through. And she's been seeing them over telehealth with a home health nurse by their side and the vital sign machine. And she said it's better care than she's ever provided these patients, because before they literally couldn't get in the office. So it's almost just like in the old days when we did home visits, which is a really wonderful development.
Well, one of the notes that ran across the screen was that there's a recent study that shows a 38% reduction in no-shows in terms of the difference between telehealth and physical offices. That's got to be good for the whole system and a money saver. And obviously, people who don't show up but maybe need the care, they're getting more care. Other comments? I think someone wanted to jump in.
Yes, thank you. Sorry for interrupting, Senator King. I just wanted to add to the question about remote monitoring and just note that we should all be tracking on the hospital at home movement. So in addition to home care, which we just spoke about, there has been in COVID and with telehealth flexibilities and a move to do hospital at home. It's really an opportunity to care for in rural communities those with serious illness. It brings care into the community. It reduces social isolation. And so it's remote monitoring kind of coupled with 24/7 remote nurse monitoring using technology. And so keeping an eye on where hospital at home goes as part of the whole telehealth movement, I think will be an important opportunity going forward in rural.
Well, and that raises the potential of more in the way of preventive care. I'm convinced that the low-hanging fruit in healthcare costs is better prevention. The cheapest procedure is the one that doesn't occur. And I think telehealth, some kind of a regular physical checkup via telehealth, people might be more willing to do, particularly if they don't have to take a day off work, or if it can be done in the evening. Anything along those lines that facilitates people utilizing and getting preventive care, I think, is going to be beneficial to all of us in terms of our dealing with the overall expenses of the system. Now, I'm getting lots of questions. Are low-volume rural providers being considered in the development of telehealth quality measures? Do you foresee challenges for rural providers in meeting existing telehealth quality measures? So clearly, that's going to be an issue going forward. Dina, do you want to take a crack at that? Rural health, are providers going to have problems dealing with the quality measure piece of this development?
Yeah, one of the benefits aside from the health benefits and the healthcare delivery benefits of value-based payment models and value-based care, is the elimination of some of the reporting burden. Unfortunately, a lot of the programs are really, they really aren't meant for lower volume providers. And what we see is when you aren't seeing as many patients, one bad outcome can really mess up your numbers and can really adversely affect provider payment, and in a way that is not really fixable by them. They can only do what they can do. And when you're dealing with, ratios, a little bit of one really sick patient can eliminate their ability to meet some of the quality metrics. So we continue at BPC to raise the issue of how to address issues, particularly for lower volume settings and for these providers, because we want these changes to support them, not to make life harder for them and make it more difficult for them to provide better care for their patients. So we continue to look at quality measures and try to figure out ways that would allow them to improve care that is judged by outcomes rather than the every little thing that needs to be reported, because it just becomes too burdensome and they're not able to keep up with it. It takes away time from actual face-to-face patient time that they are spending on a lot of this reporting, and we don't want to make that worse.
Scott, actually, a question for you. We've been talking about telehealth as a overall provision, as an overall concept, but there is a distinction between what we're doing now, visual, audio, and audio only. Is audio only effective, and as effective? Is it a stepchild of this movement, or is it also an important part? Because clearly, you avoid the whole issue of broadband, and particularly in behavioral health. I have a friend who does her consultation with her therapist every week on the telephone while walking. I mean, is that proven to be effective? Is that part of your toolkit at Acadia?
Absolutely, Senator. I would say that really at the end of the day, any way that we can improve access to care is a step in the right direction. And our experience with audio visits is a pretty small piece of our business, to be honest with you. We've had pretty good success so far with the video component, and accessing a patient, providing them their care, getting into their home through video means is a better platform for us, to be honest with you, for the care of the mental health population. But if it came down to audio or nothing, we obviously prefer access by audio. But at the end of the day, everything we've been talking about and everything that you're advocating for on our behalf as a country really does get to access. It's doing away with those restrictions, whether it's a geographic limitation, a site of service limitation. I don't think we should open up all modalities as long as we can continue to prove their efficacy. But really, I think the focus needs to be going forward in terms of how we rethink telehealth. It really has to be about continually expanding its access.
Well, and I want to just pause for a moment, and our panel are all involved in telehealth per se, but the looming issue in the background is broadband. Everything we're talking about doesn't work, except for the telephone part, doesn't work unless the patients, the citizens, particularly rural citizens, have access to a decent connection so they can utilize these services. So perhaps the center we could do another one of these sessions and talk about the Rube Goldberg broadband federal government response on broadband, and maybe we can try to talk about a more comprehensive response to be sure that happens. So I just wanted to, parenthetically within this discussion, remind everyone of how important good broadband is to realize the enormous potential of this technology. Jennifer, what do you see? I mean, I made a joke about Minnesota and Maine, but Minnesota is a largely rural state. Are people taking advantage, and will this continue after COVID? Do you think this is a COVID-only phenomenon because people don't want to leave their homes, or have we unleashed something out of the bottle that's going to the genie out of the bottle that's going to continue into the indefinite future and be a basic part of American healthcare delivery system?
Yeah, thank you, Senator. I think we have unleashed something. I'll comment first on the broadband issue that you raised, which is such an important one because Bill reminded us as we got started that there's still 25% of the country in primarily rural places that do not have broadband access, and that's even higher in certain communities, particularly in our tribal communities. And so when we think about broadband access, it's not only about bringing broadband to those communities, but it's about making it affordable for the patients and families there. Sometimes it arrives and it's simply not in the ability of those patients to pay for that. So we often think of technology as an equalizer, but sometimes it really exacerbates the disparities that exist. And so as we do broadband, it's very careful to construct our policies that make it to really work. But in terms of your question about whether we think we've unleashed something, I do. Pre-COVID, we often thought of telehealth in rural as accessing specialty care that wasn't available locally. That will continue to be true. That's what Walter's group has done such a great job of out of the Helmsley Trust supporting that. But now we're also, in addition to accessing specialty care that isn't available in remote communities, we're talking about how primary care teams and family practice teams deliver care in rural communities and do that so it's the local care that's being delivered via telehealth. And I think both parts of that are going to stick. They're going to have some staying power. It'll certainly, as I said in my earlier comments, kind of settle in at a different rate and a level. And as we better know which patients and which services and what care is right and lends itself best to telehealth, we'll have some best practices. We'll be able to redesign both the workflow and the practice and have the policy support around that. But I think it's here to stay. And I think it's not just that remote accessing specialty, but delivering care locally.
Walter, do you agree? I mean, this is something you've been working on for a long time. Do you see this as a permanent change in the healthcare landscape?
I hope so. I hope it is a permanent change. The only thing that I'm optimistically cautious, though, we're at a point right now where healthcare or telehealth can either take tremendous leaps forward or several steps back. The reason why I say several steps back is because it goes back to quality. We need to make sure there's gold standard quality care initiatives being done, because all it takes is a couple bad actors, a couple really big mistakes, and can you put a kibosh on the whole telehealth. Like I always said, it's based on quality. And just to dovetail a little bit on the quality aspect, we bet big on quality. The Helmsley Charitable Trust has recently launched a Helmsley Telemedicine Education Center to educate providers, educate mid-levels, to even educate hospital executives on how to implement telehealth, how to do it right. Because we want people our experiences. And so we don't have mistakes that set telehealth behind. Because the last thing I want is for someone to come in with a cheaper solution, so to speak, and not a quality solution, and either do harm to patients or do harm to the whole movement of telehealth. Because I think this is here for this needs to be here forever. It's the great equalizer across our rural divide. And really, it's not a rural issue, too. I could see this type of programs and what the physicians have spoken to about using it in primary care and behavioral health all throughout urban centers and suburban centers. It's all about getting people access, timely access to the quality care, and which everybody deserves. And so that's not a rural issue. Yes, it's exacerbated in the rural areas, but it's just as much as our urban colleagues, just as much of our suburban citizens. Everybody deserves quality and quality access, and this will level the playing field eventually if done correctly.
And I think the point that Jennifer made about cost is very important. You can have a great fiber connection in the middle of the city, but if you can't afford $100 a month or whatever it's going to cost you, it may as well not be there. So I think cost has got to be part of this. And remember, I started talking about the universal telephone service, and there was a recognition there that it was a basic service and that there needed to be some subsidies in order to be sure that it was, in fact, universal. Now, we're all cheerleaders. This has been a great session of everybody saying yes. Anybody on the panel, Dina, maybe I'll make you the devil's advocate. What's the opposition? What are the arguments that people will make? What are the arguments we're going to encounter in the Congress when we try to go ahead and make permanent some of these provisions? Are they going to be from physicians, from hospitals, from broadband providers? Where's the what are the negatives that we're going to encounter? Otherwise, this is something we ought to be able to do next week.
Right. I think, the big one is the money, right? Like this costs money. And without really good data showing that the outcomes are going to save money over time, we have to figure out how it's going to get paid for. So the main concern and what's tied into the fraud and abuse issue is that people don't want overutilization of services. So we need to be really circumspect about how we roll these things out, so that when we first get started, we don't make a mistake that then shuts everything down. We want to be able to keep going forward. So we want to have data to back up what we're doing, and to show that the problem is a lot of times when you're dealing with healthcare, the savings are 20, 30 years down the road. And that's just not front of mind when you're talking to legislators. So that's the big problem. And I just want to highlight, because we are continuing to have an issue in rural areas about maternal mortality and neonatal mortality and the costs associated with that. We've got to find innovative ways to get obstetric and neonatal care to these areas of the country. And more than half of rural counties don't have obstetricians, largely because of the cost of those services in those areas. So now you have variables such as transportation and taking time off work that influence healthcare. And there's a clear link between early and regular obstetric care and maternal and neonatal outcomes. So again, we have to ask whether telehealth can help save money and save and improve health of rural communities. And that'll go a long way in justifying the cost.
We have a few minutes left, and I want to remind our audience that if they use hashtag BPC, they can send questions directly in, which if you see me leaning forward, that's so I can read the questions that are coming across on my screen. I think cost clearly is an issue, and the trouble is it's hard to quantify the savings. I think, and as I mentioned, there are savings to the patients that would never be part of the quantification. All the calculation would be, well, what does it cost for the hardware and the broadband and the visits and the practitioners? But if you're talking about societal savings, I think they could be considerable. Dr. Miller, in your practice, have you seen any effect on no-shows versus people who make their appointments? Because that could be a significant factor.
Yeah, we actually see improvements with the telehealth visits in terms of no-shows. And part of that, I think, is it's just easier to schedule on the fly and get people in quickly, and then they're getting more point of care treatment. But one other group that I'd like to point out in the same vein as Dina with the maternal mortality rate is the patients that we take care of with opioid use disorder. We're seeing a lot of patients in that group use telehealth services, and I feel that they're particularly vulnerable to the dire consequences of this pandemic. Currently, in our practice, we're having them seen over group visits for their counseling, but also some telehealth visits for their medication-assisted treatment. And it's just a really important group not to forget, because I feel in this time of social isolation that problem is only going to get much worse as time goes on.
Yeah, we're suffering an epidemic, or several epidemics. Of course, COVID is the major one, but we have an epidemic of suicide, an epidemic of depression, an epidemic of drug issues. So those are all issues that we really need to deal with. Jennifer, did you have some thoughts on where the opposition might come, what the obstacles are to fully realizing the potential here?
Yeah, as I was listening to Dina, I was also thinking about another debate, I guess I'll call it, that we can predict, which is about network adequacy. So as we've seen and have demonstrated the effectiveness and success of use of telehealth, and as we're looking at how we define network adequacy, I can predict some of the policy debates might be around whether care and services can be brought entirely remotely to a community, and that counts as being an adequate network for a health plan, for example. And then that tension with what really should be local. Should we always have primary care and EMS and public health locally, which is what the Rupri Health Panel would say are essential local core services. So I predict that there will be some tension around network adequacy, and when will telehealth supplement and when will telehealth supplant what's available in rural communities? And I think there's going to be a fair amount of policy debate around that.
Well, we're not quite finished. We have some more questions, but I just didn't want to forget. I think this is going to be a very live issue in the next Congress. Uh, and I think it's a cross-cutting issue. I think it is a bipartisan or a nonpartisan issue, particularly because so many of my Republican colleagues represent rural states where these issues are so critical for their own citizens. So I think this may be, should be, one of those areas where we're able to get out of the gridlock that's afflicted us recently, and hopefully make some real progress, at least in making the COVID related provisions permanent, examining, as you mentioned, what has not worked and other areas where we should make those changes. So I want to be sure and invite the panel as well as the audience to be in touch with my office, with my colleagues, with your own senator, wherever you are, your own House of Representatives member, because I think this is going to be, as I say, a very a front burner issue in the next Congress, and we're going to need all the input and expertise we can get. So I urge everyone to take advantage of this, of what I consider a very open door for good policy making that can make a difference into the indefinite future, even beyond the pandemic. Other thoughts from our panel as we close in, Walter? What do you have for a closing argument?
Well, like I said, the future's bright. I'm very optimistic at this, and very optimistic with the future of telemedicine. Really, I'm really excited and hoping to see the rest of the world catch on, rest of the United States catch on to what we have done in the upper Midwest and what we've learned in the upper Midwest. And we've made mistakes, learn from our mistakes. We've partnered with RUPRI, we've partnered with just about all the groups that people have mentioned on here to try to make best practices. And telemedicine, I think, has to be here to stay. We can talk the reasons why, whether it's with workforce development and the lack of workforces in rural areas. You have to supplement the physicians and other specialties with telemedicine, because you cannot get a psychiatrist, for example, in these rural communities. We can't even get psychiatrists in our urban communities. There's such a shortage. And this is the only adequate, equitable way to level the playing field and to give people who call rural America home the same access to our urban counterparts. I always say your zip code should not determine your outcome. And unfortunately, where you live can determine your health outcomes. It can determine life or death at times, and that's not right. And this is one of the many tools to level that playing field, to give everyone equity. And I'm encouraged. We've been at this 10 years, and I'm really encouraged that this is front and center. Yes, it took a pandemic to bring it front and center. That might be the only benefit of this pandemic. We've had economic problems, social problems, everything because of this pandemic. But really, this pandemic has forced telemedicine to the top and forced a focus on telemedicine, because it's a necessity now. And hopefully people will see it as a necessity in the future to level the playing field.
Well, I'm going to give you the last word unless somebody else has a need to make a contribution. Any thoughts, anything that we've missed thus far? In which case, Walter, and I just want to go across the panel, Jennifer, Dina, Lisa, Scott, and Walter, thank you so much for all the work that you've done. And I think my last comment is a bit of homework, which is send to us your 2 or 3 top legislative priorities for the next Congress. This is a chance to make a difference. And as I told, right before your meeting, I had a Zoom meeting with a group of 7th graders in Maine. and they asked about what's the most important responsibility and right. What's the most important right and responsibility of citizens? And I said, it all comes down to the first three words of the Constitution: we the people. We the people. The most important right is the right to vote and participate in our government. The most important responsibility is the responsibility to vote and participate in our government. And I'm offering an invitation not only to our panel members, but especially to the knowledgeable members of the audience to give us the real life situations, the real life issues and problems, and things that we can address here in Washington, or that we can work with DHHS and CMS on the regulatory side to be sure that this works, and that it works to meet the promise that it has of expanding access and quality care to people across the country, but also in areas where there is a need, like behavioral and mental health. Huge potential. And I want to thank everyone for participating, and especially thank the Bipartisan Policy Center for giving us this opportunity. And we're going to continue with this work. I look forward to hearing from many of you, and maybe we can do this again at some point in the future and all sit on a stage together. Thank you very much, and good day. Have a wonderful day for everyone, and we're going to keep working together to solve this problem and to make this technology work for the American people. Thanks again. See you later.